Are you able to hear me? Good evening. Hear me? Yes, are you able to hear me now? Okay. Will we start? Okay. So we are going to look at the cirrhosis of liver and the complications of chronic liver disease. So I have divided this entire class. We are going to have a class of about 1.5 to 2 hours. So we'll start with the etiology of chronic liver disease, and then briefly we'll have a look at complications at a glance, and then we'll look at the evaluation of chronic liver disease. How do we evaluate for the clinical features and further complications of chronic liver disease, how to find the etiology of chronic liver disease. That is what you are going to look at in the evaluation. After that, you are going to look at all the complications, that is esophageal varices, portal hypertension, and then ascites, what is refractory ascites, what is spontaneous bacterial peritonitis, hepatorenal syndrome, hepatopulmonary syndrome, and we lastly end with hepatic encephalopathy. So that would be the agenda of this session. So let's start with etiology. So this is a little bit cumbersome in the slide. You will have to remember them. Soon as the etiology is over, everything will be conceptual. So what are the vascular causes of chronic liver disease? Firstly, the hepatic venous congestion or vascular abnormalities, vascular anomalies, then Budd-Chiari syndrome, cardiac cirrhosis. When there is cardiac cirrhosis, what happens? There is congestion in the liver, and chronic congestion can result in chronic liver disease. Then Osler-Weber-Rendu syndrome, and then the hepatotoxicity because of chronic alcohol usage or medications like paracetamol, amiodarone, methotrexate, then aflatoxins produced by the aspergillus, and then industrial chemicals such as tetrachloromethane and various pesticides. All these compounds are supposed to result in hepatotoxicity. Then metabolic disorders that are resulting in the chronic liver disease are non-alcoholic steatohepatitis. Now we call it as metabolic dysfunction associated steatotic liver disease, MAFLD, right? MASLD, or non-alcoholic steatohepatitis or non-alcoholic fatty liver disease, which was the previous name for the metabolic dysfunction associated steatotic liver disease, which is the current name for the same. Then you have hemochromatosis, Wilson's disease, alpha-1 antitrypsin deficiency, porphyrias, glycogen storage disease, cystic fibrosis, then hereditary fructose intolerance, and then inflammatory causes. There are some infections here as well due to chronic viral hepatitis B, D, and C. Then purely inflammatory causes, which are primary biliary cholangitis, primary sclerosing cholangitis, autoimmune hepatitis, parasitic infections like schistosomiasis, then leishmaniasis, malaria, IgG4 cholangiopathy, all of these can result in inflammation related chronic liver disease. So there is something called as a cryptogenic cirrhosis where the etiology of the cirrhosis is not entirely found, and if the etiology is completely unknown, we call it as cryptogenic cirrhosis. So now we are delving slightly into the complications. This image replicates, see, whenever there is cirrhosis, what happens? So here is the liver. When the liver becomes fibrosed, that is when you call it as cirrhosis, right? So when the liver becomes fibrosed, all the portal venous blood will not be entering into the systemic circulation through the hepatic vein. Okay, so the sinusoids, which forms a junction between the portal circulation and the systemic circulation, are going to get blocked because of this bridging fibrosis that is happening in cirrhosis, and this blockade will result in hypertension of the portal venous system. The blood pooling in the portal system will result in portal hypertension. So when the blood resulting in when the blood pooling in the portal venous system should go somewhere, right, it is eventually going into the systemic circulation, but with the creation of collaterals. Okay, what are these collaterals going to do? These collaterals are going to communicate portal system to the systemic venous system. Okay, so that is why it is called as a portovenous, portosystemic anastomosis. So there are multiple sites where there are collaterals. As you can see here, you have the gastroepiploic collaterals, splenorenal collaterals, and then you have mesenteric or retroperitoneal collaterals, and then you have the hemorrhoidal collaterals as well. So you have multiple sites where the portal system is going to communicate with the systemic circulation. Thereby, there is shunting of blood from the portal system into the systemic circulation, because the actual blood flow across the sinusoids is blocked because of the cirrhosis. Okay, so that is why there is initiation of portal hypertension. So when there is cirrhosis, so we are going to look at all the complications in a couple of images, in a couple of pages, just for a comprehensive understanding initially. Then we can delve deeper into each and every complication separately. So firstly, broadly understand what are the complications that are going to arise because of this. So when the patient is having cirrhosis, so you saw that there is obstruction to the flow of blood from the portal venous system into the hepatic vein and further into the inferior vena cava. That is why there is development of portal hypertension and further portosystemic anastomosis. So there is portal hypertension. Okay, so this portal hypertension will result in portosystemic shunting, and there is gastric and esophageal variceal collaterals. Okay, so because of the bulges in the esophagus and gastric varices, the patient can develop gastroesophageal variceal bleeding. Okay, and this portal hypertension will also result in hypertension in the splenic vein as well, and the patient will have splenomegaly. Okay, so because of splenic sequestration, you can also call it as hypersplenism, where the vessels get trapped in the splenic vessels. The blood cells are going to get trapped in the splenic vessels, and the patient will have sequestration of the blood cells in the spleen, and the patient will have bicytopenia firstly, and then the patient can also develop pancytopenia. All the cells, that is WBCs, RBCs, and the platelets will get sequestered in the spleen, and the patient will develop pancytopenia, though thrombocytopenia is the earliest among all the cells to get reduced, because they'll be sequestered more easily in the spleen. Okay, and this portal hypertension will also result in the increased release of nitric oxide. Okay, so there is increased stretch over the vessel wall because of portal hypertension, and that will result in excessive production of nitric oxide. This nitric oxide is going to result in splanchnic vasodilation. Okay, splanchnic vasodilation means the vessels which are supplying the intestine, liver, spleen, and pancreas, right? These are the splanchnic circulation. There is specific splanchnic vasodilatation. Because of this, what happens? All the blood in the circulation is going to pull up in the splanchnic circulation, and because of that, the blood reaching the kidneys is going to get low. Okay, on one hand, because of this splanchnic vasodilatation, there is increased rapid flow of blood. That is why there is hyperdynamic circulatory state. Okay, so the CLD, because of the increased nitric oxide release, can result in hyperdynamic circulatory state. On the other hand, splanchnic vasodilatation has resulted in the pooling of blood in the splanchnic circulation, so the blood flowing to the kidneys is reduced. So there is reduced renal blood flow. Okay, when there is reduced renal blood flow, what happens? The kidneys perceives it as if the blood is not reaching the kidneys properly, and there is activation of renin angiotensin aldosterone system. So when there is RAS activation, what happens? There is water and sodium reabsorption. On one hand, there is water and sodium reabsorption. There is increase in the hydrostatic pressure. Because of the defect in the liver itself, there is also deficiency of synthetic function of liver. Because of synthetic function of liver, what happens? There is reduced albumin production as well. So when there is reduced albumin levels in the blood, there is reduced oncotic pressure as well. So increased hydrostatic pressure and reduced oncotic pressure, what will happen? The fluid is going to seep out of the circulation into the extravascular spaces, and that will result in pedal edema, ascites. Firstly, ascites in chronic liver disease, and then you can talk about pedal edema and all. Right? Understood? So there is ascites because of this. And on the other hand, increase in nitric oxide will also result in pulmonary vasodilatation. Pulmonary vasodilation will result in the hepatopulmonary syndrome. We can discuss about how the vasodilatation can result in hepatopulmonary syndrome when we talk about the hepatopulmonary syndrome proper, when we look at the pathology itself separately. Hope you understood this. So let me just repeat again. So cirrhosis will result in portal hypertension, and portal hypertension will also result in the development of portosystemic shunting, and there are collaterals in the stomach and the esophagus. That is why there is development of gastroesophageal variceal bleeding, and because of portal hypertension there is splenomegaly as well, and a lot of blood cells get sequestered in the spleen, and the patient will develop bicytopenia firstly, starting with the platelets, and the patient will eventually develop pancytopenia as well, right? On the other hand, increased stress, wall stress on the portal vessels will also result in the nitric oxide from the endothelium, and there is splanchnic vasodilatation on the one side. Because of splanchnic vasodilatation, there is hyperdynamic circulation, and because of pooling of blood in the splanchnic circulation, there is reduced blood flow to the kidney that result in the activation of renin angiotensin aldosterone system that will further result in sodium and water retention. Okay, on one hand, there is increased hydrostatic pressure because of a synthetic dysfunction of the liver. There is reduced albumin that will further result in reduced oncotic pressure. Increased hydrostatic pressure and reduced oncotic pressure will result in the pooling of blood in the extravascular space, that is resulting in ascites and peripheral edema. So, right, you can also see that when there is ascites, what is going to happen here? So all the volume of a plasma is going to seep into the abdominal cavity or into the interstitial space in the edema. So the intravascular volume is again reduced. Okay, so thereby again the renal flow is going to reduce further. At this stage, there is when there is significantly reduced blood flow to the kidney, that will result in hepatorenal syndrome. Okay, that will result in hepatorenal syndrome. On the other hand, increased nitric oxide levels will also result in pulmonary vasodilation, and that will result in hepatopulmonary syndrome. We'll look at that clearly when we look at the pathology itself separately. Understood this? You can put it in the chat. I'll be able to observe your responses in the chat. Yes? Yes, okay. Good. Now, because of cirrhosis, we are still having a glance at the complications itself. The cirrhosis can, on one hand, there is synthetic dysfunction, right? So the synthetic function of liver is reduced. On one hand, there is reduced albumin that you saw in the previous page. On the other hand, there is also deficiency of clotting factors 2, 7, 9, 10, because these 2, 7, 9, 10 factors should be produced by the liver utilizing vitamin K from the food, right? So vitamin K dependent factors are also not being produced sufficiently. So there is deficiency of clotting factors, and the clotting factors are deficient. That's when the patient develops bleeding, the signs of bleeding like ecchymosis, purpura and all, that constitutes the bleeding coagulopathy here. Okay, and the liver is also responsible for the production of complements. So the complement levels are also reduced, and even the bile salts are also produced by the liver. So all these are deficient. The bile salts themselves are actually antibacterial, and of course you know the role of complement activation in the antibacterial activity. So when the complement levels and the bile salts are reduced in our body, what happens? The gut bacteria is going to translocate easily from the gut into the circulation, and that will result in it is going to enter from the bowel into the abdominal cavity. That will result in the infection of whatever the abdominal content, that is fluid here, because of ascites, and the patient will have spontaneous bacterial peritonitis. That is another complication of chronic liver disease. On the other hand, there is reduced metabolic function of the liver as well. So the liver is going to detoxify a lot of toxins that are accumulating in our body. When the liver metabolic function is also reduced, what is going to happen? The toxins are going to accumulate. So this toxic accumulation will result in some of them are going to cross the blood-brain barrier as well, and that will further result in hepatic encephalopathy. That will result in hepatic encephalopathy. Right? So these are the complications of chronic liver disease. We have looked at the esophageal varices, and then splenomegaly, hypersplenism, pancytopenia, and then hepatopulmonary syndrome, ascites, then hepatorenal syndrome, then we have bleeding coagulopathy, spontaneous bacterial peritonitis, and hepatic encephalopathy. These are broadly the complications of chronic liver disease. Now, we'll look at the features of liver failure. These questions must have been asked in Viva quite frequently, but we are going to look at it for once. So, what are the features of liver failure? Starting with jaundice. So, there is icteric sclera that you can see in the image here as well. And there is fetor hepaticus, musty breath because of the volatile sulfur compounds. Because of deficiency of metabolic function of liver, the sulfur compounds stay in the circulation, and that is coming out of your breath, that is felt as the fetor hepaticus or musty odor. And then facial telangiectasia. So this is because of increased estrogen levels. Again, the estrogen levels are increased in the body because of the reduced hepatic metabolism of estrogen, that is responsible for the facial telangiectasia. You can also call it as spider angiomata, which will commonly appear over the chest. And then you have palmar erythema because of vasodilatation of the palmar vessels. That can also happen because of estrogen excess. As you can see here, the palms are pink because of the vasodilatation that is happening because of excessive estrogen. Then you have Terry's nails. As you can see, the white nails here, there is also a loss of lunulae. Okay, the lunulae means the nail bed is actually pink, and there is a white a semicircle shaped or a spindle shaped structure at the base of the nail bed. That is what you call it as a lunula, that is disappearing, and the entire nail appears white. Okay, that is Terry's nails, that is seen with the hypoalbuminemia and chronic liver dysfunction. And then you have gynecomastia or decreased body hair, again because of impaired estrogen metabolism. So the estrogen keeps on building up in the men, that will result in gynecomastia and decreased, that is the loss of the secondary sexual characters like decreased body hair, loss of axillary hair and the pubic hair as well, that can happen with the males. And then ascites that you have already seen. Then caput medusae. These are again the periumbilical vessels, which are nothing but the portosystemic collaterals that are developing around the umbilicus. They will also become prominent on the abdomen, that you can observe. And splenomegaly, of course, splenomegaly is you will be able to examine it when you look at the systemic examination. And then Dupuytren's contracture. Dupuytren's contraction is because of the fibromatous deposition that is happening in the palms because of alcoholic etiology. And then ecchymosis and easy brewing, again because of the coagulability. I mean, there is coagulopathy because of reduced clotting factors 2, 7, 9, 10, because they should be produced by the liver utilizing vitamin K. And you have pruritus. See, the bile salts which should be secreted from the liver into the gut is also deficient there. So there is bile salt deposition in the skin that could be resulting in the pruritus. And muscle wasting. Muscle wasting is because of the catabolic state and malnutrition that could be happening. And then testicular atrophy and amenorrhea, again because of the estrogen excess. Okay, estrogen excess, and again peripheral edema is because of increased hydrostatic pressure and reduced oncotic pressure that you already saw. So these are the signs of liver cell failure. Now, how are you going to evaluate in a case of cirrhosis? Starting with the basic investigations, you look at complete blood picture, LFT, PT and INR, APTT, renal function test, then alpha fetoprotein, usually associated with elevated AFP, can be seen with the hepatocellular carcinoma. Okay, so CBP, you may see pancytopenia or initially thrombocytopenia in some cases. LFT may reveal all the kinds of abnormalities depending upon the etiology as well. You can see elevation in the SGOT, SGPT if there is acute liver dysfunction. and if there is chronic liver dysfunction, there can be reduction in the albumin as well. PT and INR is elevated both in chronic liver disease and acute liver failure, but specifically more specific towards the acute liver failure. Okay, renal function test may also get deranged if the patient develops hepatorenal syndrome, right? So all these investigations, the basic investigations needs to be done first, and then you can look at the ultrasound abdomen to look at the spleen size as well as the liver size, whether the liver is in the whether the patient is having hepatomegaly or is there any shrunken liver. That could be identified by looking at the ultrasound abdomen. And after that, you can also look at the non-invasive tests for after you identify that the patient is having chronic liver disease based on the basic investigations. Now you want to estimate the amount of fibrosis that is deposited in the liver. Okay, for assessing the fibrosis and the level of cirrhosis in the liver, you can do some non-invasive modalities. Actually, the gold standard method to estimate the amount of fibrosis in the liver is the liver biopsy, but liver biopsy is quite invasive. That is why we'll try to look at the non-invasive methods. So what are the non-invasive methods that we have? We have the ultrasound elastography, or this VCTE, vibration controlled transient elastography. Okay, so by doing this vibration controlled transient elastography, we are going to look at the liver stiffness measurement. You call it as LSM. Liver stiffness measurement is being found out by doing the VCTE, and a cutoff of 12.5 kilopascals is the cutoff for identification of cirrhosis. Beyond 12.5 indicates that the patient is having cirrhosis. Less than 12.5 indicates that the liver is not having that much fibrosis. Indicative of cirrhosis. Okay, then you have other modalities like acoustic radiance force impulse imaging, and we also commonly do magnetic resonance elastography. Okay, so these are the modalities with which you can identify the amount of fibrosis in the liver. Okay, these are non-invasive. You are not going to put a needle inside, you are just going to scan. And then you can also estimate some scores to predict the amount of cirrhosis. One is APRI, that is AST to platelet ratio, and you have FIB4 score that uses age, platelet, ALT and AST levels. Okay, so these are the scores to predict cirrhosis. And the single best blood test predictive of cirrhosis is platelet count. Okay, the single best test predictive of cirrhosis is platelet count. This is briefly the evaluation that is required for identification of cirrhosis. And then for identification of the etiology of cirrhosis. Okay, so identification of the etiology of cirrhosis. For that, you look at the serologies. So the commonest cause of viral hepatitis are hepatitis B firstly, and then comes hepatitis C. So you will look at the hepatitis B and hepatitis C serologies. Then you want to rule out the if it is not there, alcohol is not an etiology. Then you want to also rule out the inflammatory causes or the autoimmune causes. For that, you will look at the anti-neutrophilic antibody, then liver kidney, or anti-LKM1, then SLA, anti-SLA. All these antibodies are seen with the autoimmune hepatitis. LKM1 can also be seen with hepatitis C sometimes, but broadly LKM1 and anti-SLA, ANA primarily with the autoimmune hepatitis. Then anti-mitochondrial antibody. This is seen with the primary biliary cholangitis. Then serum iron, total iron binding capacity, serum ferritin, transferrin saturation. You must have seen these investigations when you looked at the iron deficiency anemia evaluation as well, but we are looking at the hemochromatosis here. The iron deposition in the liver can also result in the chronic liver disease. That is why you are going to look at these iron related investigations, that is serum iron, total iron binding capacity, serum ferritin and transferrin saturation. Even HFE gene testing is also for hereditary hemochromatosis. If the transferrin saturation is more than 45%, that indicates that there is significant iron deposition in the liver. Indicates that there is significant amount of iron in the circulation. And further, if you want to identify if there is any genetic causes, then you will do HFE gene, which is the most common gene for the development of hereditary hemochromatosis, that is HFE gene mutation. And then you are also going to do serum ceruloplasmin. Further, if you are not able to find any cause, you want to rule out Wilson's disease as well. For evaluation of Wilson's disease, you are going to do serum ceruloplasmin, serum copper and 24-hour renal copper excretion. Okay, so 24-hour renal copper excretion, that is 24-hour urine you are going to take and estimate the amount of copper in it. Okay, so these are the investigations that you want to do for ruling out the Wilson's disease. And then comes lastly the ascitic fluid count and culture. We are going to talk about the ascitic fluid properly when we talk about ascites, right? Now, further, firstly, we have looked at the whether the patient is having cirrhosis or not, and what are the complications that the patient could be having. That is what we saw in the previous page. Now, in this page, we have looked at what are the etiologies that could be resulting in the chronic liver disease in this patient. Now, after that, we are going to look at different complications and how are they going to present in this patient. Yes, is that okay till now? Then we are going to look at the gastroesophageal varices. Okay, so we have already seen that the portal hypertension is the cause for the gastroesophageal varices, and that will they will bleed, and the patient will have hematemesis or melena. Okay, hematemesis or melena are the most common presentations of gastroesophageal. They are nothing but the vessels, right, which have swollen, and when they bleed, the patient can develop blood in the vomiting. That is what you call it as hematemesis, and the patient can also have melena because of blood in the intestine. Okay, so when there is significant amount of blood loss, the patient can also develop hypovolemia, and the hypovolemia is visible in the form of tachycardia, hypotension, and orthostatic changes. Orthostatic changes means there is sudden amount of blood loss, and there is the patient is going to have volume depleted state, and as soon as the patient stands up, the patient will have giddiness and fall. That is what you call it as orthostatic changes here. And how are you going to manage? See, the management depends upon what kind of varices are they, whether they are whether they are bleeding or whether they are not bleeding. When they are bleeding, then you definitely have to do an invasive intervention and you want to block or remove the varices then and there. But if the patient is having non-bleeding varices, the patient could be having a small varices. Okay, so when the patient is having varices and they are not bleeding, or when they are small, then you can go ahead with the conservative management. If the patient is having medium to large sized, then start with the primary prophylaxis. Primary prophylaxis because the patient has not yet bleed. Okay, there is no bleeding yet. You want to prevent an episode of bleeding. That is why you are calling it as primary prophylaxis. So what are you going to do? You are going to give non-selective beta blockers like carvedilol or propranolol. Okay, carvedilol or propranolol should be given to reduce the portal hypertension. These drugs are going to reduce the portal hypertension, thereby reducing the risk of bleeding in these patients. And you know that the non-selective beta blockers are contraindicated in the cases of asthma or COPD or peripheral vascular disease. So if the patient is having any of these conditions like asthma, COPD or severe bradycardia and peripheral vascular disease, what you want to do as a primary prophylaxis, you can do endovascular variceal band ligation. Okay, sorry, not endovascular, that is esophageal variceal band ligation using endoscopy. Okay, endoscopic variceal band ligation, that is what you are going to do when the patient is having any of these episodes, because beta blockers cannot be given in these cases. Now, if the patient is having bleeding varices, okay, till now the patient was not bleeding, and if the patient was having small varices, only conservative management. If the patient is having large varices, then you have given either non-selective beta blockers, or if they are contraindicated, you have gone ahead with the variceal ligation. But if the varices are bleeding, then the patient may land up in shock and the patient may die then and there. Okay, a lot of times, if the patient is ignored, if the varices are not identified in the earlier stage, even the patients may die in the wards as well. Okay, the patient goes to the vomiting, the patient goes to stool, and the patient passes large amounts of black colored stool, and the patient vomits clots of blood, and the patient collapses in the bathroom itself. These kind of situations may happen if you have not identified the case at the earliest. Okay, so oftentimes, though the patient may not have hematemesis at the moment, the varices could be bleeding, and there is significant amount of bleeding that is happening inside the bowel that is not clearly apparent outside. Okay, very oftentimes, this kind of presentation can also be there. So once the patient develops hypotension or orthostatic changes with the background of chronic liver disease, think that there could be an intra-abdominal or there is bleeding from the esophageal varices, but that is not apparent clearly with the hematemesis or melena. Okay, so if the patient is actively bleeding, then firstly secure the airway. Okay, secure the airway if the patient is having massive bleeding, or if the patient is having encephalopathy, because the patient could die of aspiration. So firstly secure the airway, and after that, don't directly put a nasogastric tube, because that can further result in damage to the esophageal varices, which can exacerbate the bleeding. Okay, so that is why when the patient is actively bleeding, don't actively or routine nasogastric tube placement is avoided. Firstly, place a large bore IV cannula, because you want to replenish the fluids. So if the patient is having significant amount of blood loss, give some PRBC transfusion and make sure that the patient blood is at least 7. Okay, so the target hemoglobin should be 7 gram per deciliter. And after that, you want to stop the bleeding happening inside the bowel wall. by giving intravenous medications, you can stop that. Which are the vasoconstrictors? What are the vasoconstrictors that you want to give? You can give octreotide, somatostatin, or terlipressin. Okay, terlipressin is a vasopressin analog, right? So the octreotide or somatostatin or terlipressin, any of these drugs can be given for these drugs will result in this splanchnic vasoconstriction that will further stop the bleeding from the gastric and the esophageal varices. And you can also give prophylactic antibiotics, because the blood pooling in the gut can be a focus for, can be a medium for easier growth of the organisms. That is why when the patient bleeds, it is essential for each and every case to give prophylactic antibiotics. You are going to give intravenous ceftriaxone 1 gram IV OD for 5 days. Okay, up to 5 days, that is what you are going to give after the pharmacological therapy. Then you have, after the pharmacological therapy, you are going to do endoscopic therapy. Okay, perform upper GI endoscopy within 12 hours of presentation. And what you are going to do, after you put the endoscope, you are going to ligate the varices which are bleeding. Okay, so you want to do the variceal ligation, and if the you may have to repeat this variceal ligation after 2 to 4 weeks until the bleeding and the varices are completely eradicated. There is also something called as rescue therapy. Previously, before the advent of upper GI endoscopy in multiple hospitals, we used to have these balloons where we are going to insert this balloon into the esophagus, and you want to inflate the gastric and the esophageal balloon. Because of pressure of the balloon that we are exerting, the varices gets compressed and the bleeding is stopped. Okay, that is rescue therapy that you are going to give. I'll show you the images further. So what are you going to use? You can use a balloon tamponade, that is insertion of a tube, and you are going to inflate the balloon. The balloon is going to compress onto the varices, and it is going to stop the bleeding. So balloon tamponade or esophageal stenting can also be utilized. So when endoscopic and drug therapy fails to control bleeding, you can go ahead with this rescue therapy. Or if the patient is hemodynamically unstable and you are not able to do an upper GI endoscopy since the patient is unstable, at this situation as well, before you go ahead for the upper GI endoscopy, firstly stop the bleeding by placing this tube and inflating the balloons. Okay, so, and this should be utilized for less than 24 hours, because utilization more than 24 hours can result in the necrotic patches and even perforation as well. So complications are expected in a case of variceal bleeding on whom there is a tamponade, balloon tamponade for more than 24 hours. So it is suggested that the tamponade should be done only for less than 24 hours. And then after the patient is treated, further now you are going to give secondary prophylaxis. Again, the non-selective beta blockers, propranolol or carvedilol, you are going to give for prevention of further episodes of esophageal varices, variceal bleeding from in the stomach or the esophagus. Okay, so if the patient is not bleeding, primary prophylaxis with the non-selective beta blockers or esophageal variceal bleeding. But if the patient is having a bleeding varices, firstly give the vasopressors. Firstly, put an IV bore cannula, a large bore IV cannula. Replenish the patient with the blood if the patient has significant blood loss. Target hemoglobin is 7, and after that give vasoconstrictors that you can give. What are the vasoconstrictors that you can give? You can give octreotide or somatostatin or terlipressin. Any of these should be given, and after that you will do the variceal band ligation using endoscopy. If you are not able to do that, you can do rescue therapy. If the patient is hemodynamically unstable, you are not able to do a variceal ligation, or despite doing variceal ligation, if the patient is still bleeding, in any of these cases you can do rescue therapy using balloon tamponade or esophageal stenting. After the bleeding is completely stopped, if you want to prevent further episodes, you are going to give the patient non-selective beta blockers, that is propranolol and carvedilol. Right? So these are the balloons. So different kinds of balloons. We have Linton Naklas balloon, then you have Sengsteken Blakemore tube, and then you have Minnesota tube. Okay, so there are different. Here you have a single gastric balloon. Here you have a gastric balloon and an esophageal balloon. Here is the gastric balloon, and here is an esophageal balloon. In the Minnesota tube as well, you have a gastric balloon and an esophageal balloon. There are multiple ports here. Okay, these are the balloons similar to that of the Ryle tube that you can put. So here are the balloons that these are used for the tamponade. You can see the inflated gastric balloon here and the esophageal balloon here, and this is how it is inserted into the GI tract of this patient. So how do you, this is how you look at the esophageal varices. As you can observe here, the vessels are swollen, and as you can appreciate the swollen vessels here, these are the esophageal varices, and the varices have been ligated here. So this is the endoscope, and using negative suction, the varices are sucked inside, and this is the ribbon that is going to be tied around the neck of the varices, and this is going to get sloughed off eventually. Then, if the patient is having recurrent variceal bleeding despite doing all these modalities, the only way to reduce the portal hypertension is to do TIPS, transesophageal transhepatic. Sorry, this is what is this? PSS is portosystemic shunting. Okay, so okay, remember it as the trans. I don't exactly remember what is further. Portosystemic shunting. What are you going to do? You are going to place a stent that is communicating between the portal vein and the hepatic vein here. Okay, so you are going to place a shunt. So there is fibrosis in the liver that is resulting in the obstruction to the flow of blood from the portal vein into the hepatic vein. That is why you are placing this shunt in order to bypass the obstruction. Okay, so here is the shunt that has been placed. This is going to communicate between the portal circulation to the systemic circulation, thereby reducing the portal hypertension. So this is particularly given when the patient is refractory to pharmacological and endoscopic treatment, or if the patient is having recurrent variceal bleeding despite treatment. And the common indication is the child Turcot Pew score of class CTP is nothing but the child Turcot Pew. The depending upon the scoring of the CTP, we are going to divide them into class A, B, C, D. So the CTP class B with bleeding or CTP class C are the indications to do TIPS in this patient. I think TIPS is transjugular intrahepatic portosystemic shunting. Okay, transjugular intrahepatic portosystemic shunting. Now you are going to look at the portal hypertension. What are the causes of portal hypertension? Firstly, see here is the normal structure where on one side here is the sinusoid. Okay, here is the sinusoid, and you have the hepatic portal vein here, and you have the central vein here. Both are all the on from all the sides there are multiple portal tracts, and all the hepatic sinusoids are going to drain into the central vein, and the multiple central veins are going to combine to form a hepatic vein. So here the portal vein is going to enter here. Here is the portal vein and the sinusoid, and further it is going to drain into the central vein. All the central veins are joining together to form the hepatic vein, and the hepatic vein is going to drain into the inferior vena cava. Okay, so there are multiple causes at different levels. So there can be a pre-sinusoidal pathology, there can be a sinusoidal pathology, or a post-sinusoidal pathology. Any obstruction along this path can result in portal hypertension. So what are the pre-sinusoidal causes? They are schistosomiasis, portal vein thrombosis, and splenic vein thrombosis. Portal vein and splenic vein are definitely located proximal to that. So there is portal vein thrombosis and splenic vein thrombosis that could be resulting in the pre-sinusoidal hypertension, portal hypertension. Then you have sinusoidal causes. Sinusoidal causes are cirrhosis and liver metastasis. The bridging fibrosis that is happening in cirrhosis is going to result in the obstruction at the level of the sinusoids. That is what is called as sinusoidal hypertension occurring because of cirrhosis and liver metastasis. Then you have central vein, that is the post-sinusoidal causes. The post-sinusoidal causes are Budd-Chiari syndrome, or right heart failure, or constrictive pericarditis. After the hepatic vein drains into the inferior vena cava, when there is a block at that level, that's when you develop the Budd-Chiari syndrome. And if there is a block much more distal to that at the right heart, then there can be a right heart failure, which could be resulting in the portal hypertension, and even constrictive pericarditis, which is constricting the flow of blood into the right heart, again could be resulting in the portal hypertension. So there are pre-sinusoidal causes, sinusoidal causes, and post-sinusoidal causes. All of these could be resulting in portal hypertension. And what are the causes of ascites? So you have already looked at the pathogenesis of etiology, right? There is increased hydrostatic pressure because of RAS activity, and there is also reduced oncotic pressure because of hypoalbuminemia. Both of them are resulting in deposition of fluid in the extravascular spaces. One is ascites and the other is pedal edema. So what are the causes of ascites? So the causes of ascites can be hypoalbuminemia, reduced protein in the serum itself. That is why that could be resulting in the reduced oncotic pressure. They are nephrotic syndrome, severe malnutrition, and protein losing enteropathy. All these three cases, there is significant nephrotic syndrome, there is proteinuria, and there is significant protein loss from the body. And reduced protein in the circulation or in the effective arterial volume, what happens? The reduced oncotic pressure, the fluid is going to seep out. Severe malnutrition, again the patient is having protein deficiency. Even in protein losing enteropathy as well, the protein is lost in the stool itself, and again the patient will have protein deficiency. And when the patient is having malignancy, so what are the causes of malignant ascites? They are peritoneal carcinomatosis, metastasis, and lymphoma. Okay, and certain infections like tuberculosis, intra-abdominal tuberculosis can also result in the deposition of fluid in the abdominal cavity. Even pancreatitis can also result in fluid deposition in the cavity, abdominal cavity. So the clinical presentation and all, abdominal distension, you know about the fluid thrill, shifting dullness, we are not going to discuss about it. We are going to directly look at the ascitic fluid analysis. So how are you going to evaluate a patient? Firstly, you are going to do all the investigations that we already did in the case of chronic liver disease. In addition to all of them, we are going to assess the fluid as well by looking at the total count, differential count, then levels of protein, albumin, and SAG ratio. SAG ratio is nothing but serum albumin, ascitic albumin gradient. Okay, serum albumin to ascitic albumin gradient. So serum albumin minus ascitic albumin. Am I audible now? Okay. So when you look at the acidic fluid analysis, this is still showing error. Can you? Yes, I'm okay. I'm audible. Okay. So when the patient is having this ascites, you are going to look at the acidic fluid analysis in addition to all the investigations that we did for the chronic liver disease. So you are going to look at the total count, differential count, the protein, albumin and SAG ratio, serum albumin, acidic albumin gradient. You are going to subtract the acidic albumin from the serum albumin and you are going to find out the ratio. Then cultures in the blood culture bottles. So you are going to take the fluid, acidic fluid, and you are going to put it in the blood culture bottles, and you are going to send it for microbiology, and then you are going to do gram stain, acid fast staining, cytology for malignancy, CA125 levels, and carcinoembryonic antigen levels. All these are for identifying the malignancies, and you also have to look at the triglyceride levels if you want to rule out the chylous ascites, and amylase levels if you want to rule out the pancreatitis related ascites. Okay, so these are all the investigations that you want to do for identifying different etiologies based on the acidic fluid analysis. So based on this acidic fluid analysis, firstly, the first step after looking at the report is to look at the SAG ratio. The SAG ratio is serum albumin acidic albumin gradient, right? So when the SAG ratio is more than 1.1, that indicates that the patient is having portal hypertension. Okay, so when the SAG ratio is less than 1.1, then it indicates that the patient is not having hypertension, not having portal hypertension. So when the SAG ratio is more than 1.1, that indicates portal hypertension. SAG ratio less than 1.1 indicates it is not the cause is not a portal hypertension. So in the portal hypertension as well, now you look at the acidic fluid protein level. If the acidic fluid protein level is more than 2.5 gram per deciliter, okay, if the acidic fluid protein level is more than 2.5 gram per deciliter, then the causes could be obstruction at the level of hepatic vein or heart or the inferior vena cava. Okay, so what are they? There could be a hepatic vein thrombosis or the right heart failure or the constrictive pericarditis or Budd-Chiari syndrome, sometimes myxedema. Okay, these are the causes of high SAG, high protein ascites. You call it as high SAG, high protein ascites. When the acidic fluid protein is less than 2.5 gram per deciliter, then the cause is cirrhosis. Okay, then the cause is cirrhosis. You could ask me, why is there low protein in? Okay, so when there is an obstruction at the level of hepatic vein or the inferior vena cava or at the heart, the pressure that is built up in the sinusoids is going to result in the seepage of significant number of protein into the intra-abdominal cavity. That is why there is high protein in the acidic fluid, whereas even though the SAG ratio is more than 1.1, the acidic fluid protein is less than 2.5 gram per deciliter in cirrhosis. Okay, that is what you need to remember. And then when the patient's SAG ratio is less than 1.1, that indicates that the patient is having ascites, which could not be because of portal hypertension. And when the acidic fluid protein is more than 2.5, then the causes could be some abdominal cause itself. It could be a malignancy originating in the intra-abdominal cavity, which is peritoneal carcinomatosis, or any kind of inflammation or infection in the abdominal cavity, that is pancreatitis or tuberculosis or even chylous ascites. Okay, so all these causes will result in the acidic fluid protein of more than 2.5 gram per deciliter along with the SAG ratio of less than 1.1. SAG ratio less than 1.1, what do we mean by that? There is excessive amount of protein in the acidic fluid more than that of the serum. So in a high pressure related ascites, as in case of the obstruction with the hepatic vein, IVC or heart, or with the portal vein, whatever the protein is there in the circulation, only that is going to seep out into the abdominal cavity. That is why the protein in the acidic fluid cannot go beyond serum albumin, right? So but here this is not the case in inflammation or infection or malignancy. These causes will result in protein accumulation in the bowel itself, which is not dependent upon the serum albumin level. That is why the acidic fluid albumin can sometimes be greater than serum albumin here as well. That is why the SAG ratio is less than 1.1, means that there is no portal hypertension. It could be some other cause. When the acidic fluid protein is more than acidic fluid protein is more than 2.5 gram per deciliter, it is peritoneal carcinomatosis or pancreatitis or tuberculosis or chylous ascites. And if the acidic fluid protein is less than 2.5, that means that there is protein loss as well. Again, the acidic fluid is not having sufficient protein. It means that there is coexistent protein loss as well. That could be because of nephrotic syndrome or protein losing enteropathy. In nephrotic syndrome, there is loss of protein in the urine. In protein losing enteropathy, there is loss of protein in the stool itself. Right? Now, when you look at the ascitic fluid protein in spontaneous bacterial peritonitis, it is typically less than 1 gram per deciliter. Okay, but when there is a secondary peritonitis or surgical peritonitis, if there is a disruption in the the intestinal wall, that could be resulting in the peritonitis because of a small perforation or even with the iatrogenic causes. Whatever could be the cause, if there is a proper clear-cut disruption in the bowel wall and there is surgical cause of peritonitis, then the protein levels will be more than 1 gram per deciliter. But usually in the spontaneous bacterial peritonitis, it is less than 1 gram per deciliter. And the neutrophil count is more than 250 cells per millimeter cube. When the neutrophil count is more than 250 per millimeter cube, that is indicative of spontaneous bacterial peritonitis, or the total leukocyte count of more than 500 per millimeter cube as well, you can consider it as spontaneous bacterial peritonitis. And ADA usually in the range of 35 to 40. When it is more than 35 to 40, that's when you call it as tubercular peritonitis. Then triglyceride levels, when they are more than 200 milligram per deciliter, some studies have shown that even 81 can also be considered, which could be identifying most sensitively. But usually we consider 200 as the cutoff. When the triglyceride level is more than 200 milligram per deciliter, you call it as ascites. When the RBC levels are more than 10,000 per millimeter cube, you call it as ascites because of increased hydrostatic pressure. So you want to restrict fluid intake as well as the sodium intake in the patient. So you want to restrict the sodium intake to less than 2 grams per day or less than 5 grams of sodium chloride per day, and you should not add any salt to the diet. And the fluid restriction should also be less than, it should also be done and should be restricted to less than 1 liter per day. And in addition to the salt and fluid restriction, you want to start the patient on diuretics. The best diuretic here is a diuretic of choice, fluid from the abdomen by doing paracentesis. The preferred location is the lower left quadrant, 2 finger breadths upwards and medially from the anterior superior iliac spine. Okay, you can identify the anterior superior iliac spine, and now you move 2 finger breadths above and medially. That's when you identify a point where you will insert the needle and you are going to remove the fluid out of the abdomen. And you can see there is also a container here to which the tube is being attached using this cannula, which is inserted into the abdomen at that particular point, and this tube is going to drain all the fluid into the tumbler or the container. Okay, then we look at the refractory ascites. So what is refractory ascites? When the ascites is not responding to the diet with less than 5 grams of salt per day, along with the usage of maximal dosage of steroids, that is 160 milligrams of furosemide and 400 milligrams of spironolactone, okay, for at least a week. So you have put the patient on fluid restriction, salt restriction, maximal dosage of spironolactone, that is 100 milligrams per day, and maximal dosage of furosemide 160 milligram per day. If you are using all of that for 1 week and still the patient is not responding to any of these modalities, that's when you call it as refractory ascites. How are you going to treat this patient? So you avoid AC inhibitors or ARBs or any NSAIDs. Okay, all of these could be resulting further in the acute kidney injury. Okay, so when the patient is already having refractories or ARBs or NSAIDs, and also try to avoid high dose beta blockers because the patient could be landing in hypotension or hepatorenal syndrome. When the patient is having hepatorenal syndrome as well, you want to avoid usage of high dose beta blocker. And since the patient is not responding to any of these drugs, you want to remove the fluid from the abdomen by doing paracentesis. But what are you going to do? You are going to do large volume paracentesis. You call it as large volume paracentesis when you remove more than 5 liters of fluid at a time. Okay, and do any of the fluid restriction or salt restriction, further higher dosages of maximum dosages of furosemide or spironolactone. If the patient is not responding to any of these treatments, then at least for a week, then you can do large volume paracentesis. Stop NSAIDs, beta blockers, AC inhibitors or ARBs. Do large volume paracentesis plus albumin infusion. You can also give vasoconstrictors. You want to reduce the splanchnic vasodilation. And if the patient is not responding to any of this, place a shunt, that is transvehicular intrahepatic portovenous shunting, and then the last resort is to. So when the patient is having ascites and cirrhosis alone without bleeding, the antibiotic prophylaxis is not routinely recommended because there is no significant risk of translocation of bacteria from the gut into the abdominal cavity unless there is some medium for culture. If there is bleeding in the gut, it forms a medium for culture of bacteria in the gut, and that can further result in the translocation of bacteria from the gut into the intra-abdominal cavity. That is why if the patient is having cirrhosis and ascites alone, the antibiotic prophylaxis is not routinely recommended, but if the patient is having concurrent GI bleeding, then it is definitely recommended. So for coagulopathy, so if the patient is having any bleeding, ecchymosis or increased risk of bleeding or purpura, then if the patient is having a deranged PT or INR when you look at the investigations, then supplement the patient with vitamin K. 5 to 10 mg per day for 3 days covers any deficiency of vitamin K. But if the patient is having very severe liver dysfunction, despite supplementing the patient with vitamin K, the liver will not be able to produce clotting factors, but still you want to replenish the patient with vitamin K. And after that, if the patient is still not responding, or if the patient is having active bleeding or disseminated intravascular coagulation, see if you supplement the patient with vitamin K, and if there is any liver left to produce clotting factors, it takes at least 6 hours for it to produce clotting factors, but which could be life threatening for the patient if the patient is already having bleeding. Okay, so it takes 6 hours for the liver to produce clotting factors utilizing vitamin K. So if you want to suddenly or immediately stop the bleeding, you want to supplement the patient with fresh frozen plasma, or you want to replace the patient's plasma using plasmapheresis. So you want to give fresh frozen plasma, or you want to do plasmapheresis in a patient of active bleeding or disseminated intravascular coagulation. The other alternatives are prothrombin complex concentrates, which contains factors 2, 7, 9 and 10. And if the patient is also having fibrinogen deficiency, you can give cryoprecipitate for this patient. Okay, so vitamin K will take 6 hours for the liver to replenish the vitamin K dependent factors 2, 7, 9, 10, and waiting for the liver to produce clotting factors in a case of already in a known case of chronic liver disease could be detrimental if the patient is having active bleeding. That is why you want to give any of these 3 alternatives, that is fresh frozen plasma or prothrombin complex concentrate or cryoprecipitate, depending upon what is required for the patient. Now let's move on to the spontaneous bacterial peritonitis. See, spontaneous bacterial, why did we call it as spontaneous bacterial peritonitis? Because there is no proper disruption in the gut wall. Okay, there is no immediate visible cause for development of peritonitis. The only suggested cause is the translocation of gut bacteria from the intestine into the intra-abdominal cavity. Okay, so the infection of the ascitic fluid in the absence of any focal intra-abdominal surgically treatable source of infection. Okay, when there is no surgically treatable cause of infection, that is when you label it as spontaneous bacterial peritonitis, provided the patient should be having a chronic liver disease with ascites. Okay, that's when you call it as spontaneous bacterial peritonitis, and the most common cause is E. coli. And the secondary bacterial peritonitis is caused by bacterial infection from a surgically treatable intra-abdominal source, that is known. So what are the factors involved in the pathogenesis of spontaneous bacterial peritonitis? They are intestinal microbiota alteration. Usually the gut bacteria usually will have a lot of commensal bacteria, which is usually harmless for the patient. But if there is any microbiota alteration in the composition of the gut bacteria, which could translocate and could infect the ascitic fluid. Bacterial translocation and altered intestinal permeability, that is what is the reason for the bacterial translocation. And finally immune dysfunction, because the liver is not producing sufficient levels of complement as well. So when the complement deficiency is there, obviously the patient is going to develop easier infection, because complement deficiency will increase the risk of bacterial infections here. Even the bile cells are also not being produced by the liver, and which are actually antibacterial. So when they are deficient, there is easier growth of bacteria. So there is immune dysfunction here as well. So what are the further risk factors? Low ascitic fluid protein concentration. So a low ascitic fluid protein concentration indicates that there is low complement levels as well. And when there is upper GI bleeding, so when there is active upper GI bleeding, it could be acting as a culture for the growth of bacteria. I mean the medium for culture of the bacteria. And prior episodes of spontaneous bacterial peritonitis is also a risk factor for the further development of episodes of spontaneous bacterial peritonitis. And what are the clinical features? The patient could develop fever and chills. Of course, because the entire abdominal cavity is filled with bacterial infected fluid, the patient will have diffuse abdominal pain, guarding and rigidity, and the encephalopathy can be resulting because of the accumulating toxins on one side, and because of this infection as well. So encephalopathy could be resulting because of spontaneous bacterial peritonitis, and the definitive diagnosis requires ascitic fluid analysis. So when they look at the total count and differential count, the total count of WBC is more than 500 cells per millimeter cube or cubic millimeter, or if the polymorphonuclear cells or neutrophils are more than 250 per millimeter cube, that's when you diagnose a case of spontaneous bacterial peritonitis. And further, well, so what are you going to do? WBC more than 500 or neutrophil more than 250. LDH levels are increased and glucose is less than 50 because most of the glucose in the acidic fluid is utilized by the bacteria for its growth. So the glucose is deficient, and proteins are less than 1 gram in spontaneous bacterial peritonitis, more than 1 gram in secondary bacterial peritonitis. And this secondary bacterial peritonitis, this increased levels of protein could be because of exudation. And culture positivity, because the patient's infected, the abdominal fluid is infected. When you send it for culture, the culture may yield some bacteria. Usually the spontaneous bacterial peritonitis is monobacterial, only one kind of bacteria may be found on culture, but the secondary bacterial peritonitis, because of disruption with the gut, could be resulting in a polybacterial culture. So when you send it for culture, it may yield multiple different types of organisms in the culture. And carcinoembryonic antigen, when it is more than 5 nanogram per ml, it could be because of perforation. Okay, secondary bacterial peritonitis because of perforation. In that particular case, CEA level may be more than 5 nanogram per ml. And so for if the patient's acidic fluid is red and it is appearing hemorrhagic, that is, you call it as hemorrhagic acidic fluid when it is more than 10,000 RBC per millimeter cube, deduct one polymorphonuclear cell per 250 red blood cells. Okay, so when you are counting for the total amount of leukocytes, when the red blood cells are more than 10,000, for every 250 red blood cells, reduce one WBC count, and then you finally calculate the number of WBCs per millimeter cube. Then you have bactericidis. What is bactericidis? See, spontaneous bacterial peritonitis means there is growth of bacteria in the abdominal cavity, along with there is increased levels of neutrophils also. But here bactericidis means the neutrophil count is normal, that is less than 250 cells per microliter, 250 cells per millimeter cube, and there is positive acidic fluid culture. The bacteria is being grown in the acidic fluid, but the cells are less than 250 per millimeter cube. And there is when the patient is having bactericidis, the patient is not having the clinical features as such, right? So since there is no active inflammation or recruitment of neutrophils into the abdominal cavity, the patient may sometimes be asymptomatic as well without any fever, but there is high risk of progression to spontaneous bacterial peritonitis. So usually if the patient is not having any fever, you can repeat paracentesis and again start the patient on antibiotics if the culture still yields bacteria. Okay, if the patient is not having any fever, do a repeat paracentesis, send for culture, and if the culture is still yielding bacteria, then you can start the patient on antibiotics. But if the patient is having fever, straight away start the patient on antibiotics. Okay, so the presentation of bactericidis can be varied. So the patient could be asymptomatic or patient could be symptomatic. If the patient is having symptoms with fever, you will start with the antibiotics. If the patient is asymptomatic, you will again do a culture, again do paracentesis, send it for culture, identify the organism, and again start antibiotics. This is about bactericidis. Now let's compare the spontaneous bacterial peritonitis versus secondary bacterial peritonitis. This is what you already know about. So there is no evident source for the spontaneous bacterial peritonitis. Okay, there is no clear-cut identifiable surgical cause for development of peritonitis. That is when you call it as spontaneous bacterial peritonitis. But if there is a clear-cut source, it could be a secondary bacterial peritonitis. And microbiology-wise, the spontaneous bacterial peritonitis is monobacterial, usually aerobic causes, and polymicrobial cause multiple bacteria can be found out in secondary bacterial peritonitis. And the polymorphonuclear count, the or the neutrophil count is more than 250 per millimeter cube or per microliter in spontaneous bacterial peritonitis, whereas it is more than 10,000 in secondary bacterial peritonitis. And the protein levels are less than 1 gram per deciliter in spontaneous bacterial peritonitis, more than 1 gram in secondary bacterial peritonitis. And the glucose levels are usually normal in spontaneous SBP, and it is less than 50. A lot of it is being consumed by the bacteria inside the intra-abdominal cavity. It is usually normal in spontaneous, and it is less than 50 in secondary bacterial. And LDH is also usually reduced in spontaneous bacterial peritonitis. It is significantly elevated above serum levels in secondary bacterial peritonitis. Right? So this is a clear-cut distinction between the spontaneous bacterial peritonitis and secondary bacterial peritonitis. So how are you going to treat this case? So the treatment of choice is a third generation cephalosporin. The drug of choice is cefotaxime or ceftriaxone. Okay, cefotaxime 2 grams IV TAD or ceftriaxone 1 gram IV TAD is usually given. Then further you can escalate the antibiotics to piperacillin tazobactam if there is hospital acquired infection or if there is a recent exposure to antibiotics already. Okay, and always supplement the patient with intravenous albumin, because the IV albumin has shown to be reducing mortality in cases of spontaneous bacterial peritonitis. And if the patient is having hypotension or acute kidney injury, again discontinue beta blockers. So beta blockers should be discontinued if the patient is having refractory ascites, or if the patient is having volume depleted states, if the patient is having shock, or if the patient is having hepatorenal syndrome. All these are the contraindications for beta blockers. Okay, and the secondary prophylaxis should be given after the patient gets treated with these antibiotics. You want to prevent the further episodes of spontaneous bacterial peritonitis. So for that, you are going to supplement the patient with ciprofloxacin or norfloxacin. You can also use cotrimoxazole in these patients. Okay, this is secondary prophylaxis for further prevention of episodes of secondary bacterial peritonitis. And then you have the hepatorenal syndrome. Okay, hepatorenal syndrome. So what is hepatorenal syndrome? The name itself is telling you the renal injury resulting because of the liver damage. Okay, the chronic liver disease resulting in the renal injury, that is what you call it as hepatorenal syndrome. So there is impairment of renal function occurring in patients with advanced liver disease. Okay, so there are two types of hepatorenal syndrome, type 1 or type 2. Type 1 is also called as the AKI related HRS, acute kidney injury HRS. The other one, type 2, is called as the NAKI HRS or non-AKI related HRS or HRS CKD. Okay, so in type 1 or AKI related HRS, the trigger could be a spontaneous bacterial peritonitis or any infection or a major surgery or GI hemorrhage. Any of these could be the trigger, and there is rapid decline in the renal function in case of AKI. Whereas in non-AKI, it is the word itself is telling you non-AKI. It is a chronic kidney disease like presentation related to the liver disease. Okay, so there is gradual or steady decline in the kidney function, which is, and the patient could also be having a refractory ascites because the diuretics will not be acting on this already damaged kidney. Okay, since the kidneys are not responding properly, the kidneys are not functioning properly, despite the maximal usage of, despite usage of diuretics at the maximal dose, the patient is not going to respond. That is why we stop diuretics as well. You are directly going to do large volume paracentesis, and further, if the patient is not responding, you are going to do TIPS and liver transplant as the last resort. So this patient could be having a refractory ascites, and the renal dysfunction is steady and progressive. Okay, and this has a better prognosis than that of type 1 or AKI related HRS. So what is the diagnostic criteria? The main diagnostic criteria is that the HRS is a renal dysfunction of exclusion. So why are we calling it as exclusion? One is that the patient should not have any other renal parenchymal disease. Okay, so firstly, the patient should have cirrhosis with ascites, and after that there should not be any renal parenchymal disease. So this will also satisfy the definition of AKI. So the diagnosis of AKI according to the following criteria: an increase in creatinine of more than 0.3 milligram per deciliter in the last 48 hours, or more than 1.5 times the baseline within 7 days. Okay, so the creatinine elevation should be 0.3 milligram per deciliter in the last 48 hours, or it should become at least 0.5 times the baseline within 7 days. Okay, that is in relation to creatinine, or there can be a reduction in the urine output to less than 0.5 ml per kg for at least 6 hours. Okay, so the urine output is reduced to less than 0.5 ml per kg per hour for at least 6 hours. If any of these two is satisfied, that's when you call it as AKI. And the patient will not have any improvement after 2 days of albumin infusions and the diuretic withdrawal. Since the patient will not anyway respond to the diuretics here, after you remove the diuretics, and see, if you have given more and more diuretics, what happens? The patient could be having volume depletion as well. That could be resulting in acute kidney injury. That is why we are withdrawing the diuretics as well. So after you withdraw the diuretics and after you consecutively give albumin for that patient, despite doing this, if the patient is not responding, then again it could be a HRS AKI. And there should not be any shock, because again shock can result in renal dysfunction. Excessive usage of diuretics resulting in volume loss could be precipitating acute kidney injury, or shock, hypotension, reduced renal blood flow can be resulting in renal injury, and there should not be usage of any nephrotoxic drugs. Okay, there is no concurrent or recent usage of nephrotoxic drugs. You are ruling out all these causes. Okay, you are ruling out the shock, you are ruling out any causes of reduction in the renal blood flow, and you are ruling out the nephrotoxic agents as well. And there are no signs of parenchymal liver disease. So when you look at the proteinuria, the proteinuria should not be more than 500 milligram per day. Okay, if the patient is having more than 500 milligram per day, it is indicative of a parenchymal kidney disease. So you want to rule out any parenchymal disease as well. So there should not be proteinuria, there should not be microhematuria, and there should not be any abnormal renal ultrasonography. Okay, if everything is ruled out, but still the patient is having elevated creatinine or the reduced urine output, as I told you, increase in 0.3 or up to 1.5 times the baseline, or reduction in the urine output to less than 0.5 ml per kg per hour for 6 hours. If any of these two satisfied, despite all these causes ruled out, with the presence of ascites and chronic liver disease, then it is HRS-AKI. So what is the conclusion here? HRS-AKI is a diagnosis of exclusion, not a diagnosis of inclusion. You have ruled out all the other causes of kidney disease with the background of CLT if the patient is having renal injury, that is HRS, hepatorenal syndrome. Now the treatment is liver transplantation is the definitive management, and the patient is if the patient is having HRS-AKI, acute kidney injury means there is probability of salvaging of kidney, so you can use vasoconstrictors to shunt the blood flow or increase the blood flow from the splanchnic circulation to systemic circulation, thereby improving the renal blood flow. That is why you want to give splanchnic vasoconstrictor. That is why you want to give terlipressin or norepinephrine, or else you can also give midodrine or octreotide. All these are vasoconstrictors. They are going to vasoconstrict the splanchnic circulation and thereby diverting the flow of blood from the splanchnic vessels to renal vessels, thereby improving the renal blood flow, probably improving the renal function. Okay, so in a case of acute kidney injury, there is a transient renal dysfunction which could improve with the resuming blood flow to the kidney. That is what is the purpose of giving vasoconstrictors here. And you should add albumin in all the cases, be it in the refractory ascites or spontaneous bacterial peritonitis or hepatorenal syndrome. Albumin will reduce the mortality in all these cases. That is why you want to add albumin in all these cases. And in case of HRS non-AKI, it means that the patient is having CKD, chronic kidney disease, which will not respond to improving renal blood flow because the kidney itself is damaged. Okay, the patient could be the patient should undergo dialysis, and eventually liver transplant is the definitive management for the hepatorenal syndrome as well. Yes, and I hope you understood this. So this is all about ruling out all the renal parenchymal diseases, and the disease is because of reduced blood flow to the kidney, which we have already discussed in the initially when we looked at the glance of all the pathogenesis of chronic liver, hepatorenal syndrome at the beginning. Now let's look at the hepatopulmonary syndrome. See, we have also seen the increased levels of nitric oxide levels in the blood are responsible for the pulmonary vasodilatation, and that is resulting in hepatopulmonary syndrome. The concept is very interesting and also important for you. Once you understand this, you will never forget because this is quite simple and you will also easily understand. Firstly, this is a normal alveolus, and here is the vessel which is getting oxygenated because of the flow of blood. Okay, so here is the pulmonary vein. Sorry, here is the pulmonary artery, and here is the pulmonary vein carrying the oxygenated blood, and here are the capillaries. This could be a level of capillary where the oxygen in the alveolus is diffusing into the blood, and the hemoglobin, the oxygen is bound to the blood, and the deoxygenated blood is being transformed into the oxygenated blood here, right? Here is the pulmonary artery, and here is the pulmonary vein where you can see oxygenated blood. And while the blood is flowing in this direction, the blood is being oxygenated because of the presence of oxygen in the alveolus. Now, what is happening with the hepatopulmonary syndrome? In the hepatopulmonary syndrome, the vessels are dilated. The vessels are significantly dilated, and there is development of the shunts as well. So, on one hand, you can see the diameter or the lumen. The lumen is significantly widened. Okay, so what happens when there is widened? The blood flows across this dilated vessel fastly. Okay, so fast that there is not enough time for the alveolus to oxygenate the blood. So the oxygen from the alveolus is not going to diffuse into the blood, and there is insufficient oxygenation. So you can see some RBCs are still deoxygenated and some of them are oxygenated. That is why you are calling it as partially oxygenated blood. And there are also development of shunts. Okay, there is development of shunts because of nitric oxide. So through these shunts, the deoxygenated blood is going to bypass these oxygenation, and it is going to combine and it is going to join into the pulmonary vein. So the blood from the pulmonary artery is going to directly bypass the oxygenation and going to enter into the pulmonary vein. Okay, so like this, partially oxygenated blood and rather deoxygenated blood is going to enter from the pulmonary artery into the pulmonary vein through the shunts and the dilated vessels. Now what happens when the patient stands up? Because of gravity, all this shunting happens at the basal lobes. Okay, while the patient lies down, there is a large amount of area, there is a large surface area of the lung along which there can develop, I mean, there can be oxygenation. But when the patient stands up or sits up like this, because of gravity and the vessels are also dilated, all the shunting of blood happens at the lower lobes, and the blood will easily shunt because there is reduced surface area for the oxygen to enter into the blood as well, right? So when there is reduced surface area, when the patient sits up or when the patient stands, there is desaturation. That is what you call it as orthodeoxia. And the patient will also have shortness of breath when the patient lies supine or when the patient stands up. That is what is called as a platypnea. Okay, you must have encountered orthopnea in a case of heart failure where the patient develops breathlessness when the patient lies down horizontally. But if the patient sits up from the lying down position, that's when the patient develops shortness of breath, in this case because of shunting of blood in the lower lung lobes, right? So when the patient sits up, the patient develops shortness of breath. This is called as platypnea. And when you look at the saturation will fall down to the arterial desaturation is more than fall down to more than, I mean, that is, if the patient had 97% on room air while the patient is supine, if the saturation falls down to 94, that is more than 3% fall in desaturation when the patient sits up, that is when you call it as orthodeoxia. Okay, so platypnea and orthodeoxia are the clinical features here that you see with the hepatopulmonary syndrome. So what are the clinical features? The patient will have dyspnea, platypnea, SOB at standing or sitting position, and then orthodeoxia, that is arterial desaturation with that is saturation fall of more than 3% at standing position. And so for screening, you look at the oxygen saturation alone. And for diagnosis, you need to do a contrast echocardiography or bubble echocardiography. Okay, contrast echocardiography or the bubble echocardiography is the investigation of choice. And you can also appreciate the arterial to alveolar oxygen gradient. Okay, so you can see the alveolar oxygen will be high and the arterial oxygen will be low because there is deficient oxygenation. When there is increased gradient of this artery to alveolar oxygen gradient, that is when you diagnose this hepatopulmonary syndrome. And how do you treat this? There is no other way. You can either supplement oxygen, you want to give more oxygen to the patient, or you can do liver transplantation, which is definitive. Okay, only when you do liver transplantation, there is reduced portal hypertension, reduced nitric oxide, and there is reversal of these shunts which are formed in the lungs. Okay, this is about hepatopulmonary syndrome. Hope you understood the pathophysiology. Only when you understand pathophysiology, it will be easier for you to understand the clinical features as well. Now, let's look at the last clinical complication, which is hepatic encephalopathy. So, hepatic encephalopathy, the encephalopathy arising because of liver failure. Okay, so what are the different types? There are three types of hepatic encephalopathy. A for acute liver failure. Okay, so the hepatic encephalopathy originating or arising because of acute liver failure is the type A. Type B hepatic encephalopathy could be because of portosystemic bypass. See, the hepatic encephalopathy is a side effect of portosystemic shunting. So there is TIPS, right? Transjugular intrahepatic portosystemic shunting, where you are shunting the blood from the portal circulation to the systemic circulation. See, the liver in between is not only shunting the blood or sending the blood from the portal venous system into the systemic venous system, it is also detoxifying the blood flowing through it. Okay, so when you put the shunt through it, the detoxification of liver is completely bypassed and all the toxins in the portal system is going to enter into the systemic system, systemic venous system, and it is eventually going to cross the blood-brain barrier and the patient will eventually develop hepatic encephalopathy. So this portosystemic shunting that is developing inside the patient or iatrogenically placed because of the TIPS can exacerbate the development of hepatic encephalopathy. Okay, so this is a side effect. Hepatic encephalopathy is a side effect of placing a TIPS as well. Or also there is physiological development of that is pathological development of portosystemic shunts, which could be resulting in hepatic encephalopathy here as well. And lastly, due to cirrhosis. C for cirrhosis or chronic liver disease. A for acute liver failure, C for cirrhosis, B for bypass. Okay, remember B for bypass, that is portosystemic bypass or shunting without intrinsic liver disease. So there is no intrinsic liver disease here in B and there is only portosystemic bypass. The clinical features of hepatic encephalopathy is understood by using the West Haven grading. Okay, this has been there ever since I was in MBBS as well. So it has been divided into grade 0, 1, 2, 3, 4. Grade 0 is called as the minimal hepatic encephalopathy. So depending upon the level of consciousness, intellectual ability and behavior and the neurological findings, this has been classified. So at grade 0, the patient is conscious and then behavior of the patient is also normal and examination is also normal. Okay, even when you look at the psychomotor testing, there are multiple psychometric tests which you can do for the diagnosis of hepatic encephalopathy. All of them are also normal, that is 0. And then in 1, remember all the A's. So the awareness is reduced, the patient will have anxiety or euphoria, and there is altered sleep wake cycles or altered sleep patterns. And when you look at the intellect and behavior, the attention span of the patient is reduced, and the patient will also not be able to do any addition or subtraction. There is impaired addition or subtraction. Here also you can remember A here. And in neurological findings wise, there is another A here, which is asterexis. The first one is A. Awareness is lost, attention is lost, and even the patient will develop asterexis. Then grade 2, where the consciousness is reduced to some extent and the patient becomes lethargic. And when you look at the intellect, the patient becomes disoriented and the behavior is also inappropriate. And there is obvious asterexis in this patient, and there is slurred speech. Okay, slurred speech is in grade 2. And then in grade 3, the patient's consciousness is much more altered, where the patient feels drowsy and somnolent, but still with commands the patient is arousable. And there is gross disorientation with bizarre behavior in grade 3, and there is muscular rigidity, clonus and hyperreflexia, as if there is some central neurological dysfunction. Okay, with grade 3, like a case of stroke, the patient will have muscular rigidity, hyperrigidity, clonus and hyperreflexia. Okay, rigidity, hyperreflexia and clonus the patient will develop in case of grade 3. And lastly, in grade 4, the patient is in coma, and in relation to neurological findings, the patient will have decerebrate rigidity. And sometimes in decorticate rigidity is also seen, but decerebrate rigidity is the most prominent one that you see here. And the EEG will show triphasic waves. Okay, the EEG will show triphasic waves. So there is decerebrate posturing and triphasic waves in grade 4 hepatic encephalopathy. So the 0 is entirely normal, 1 is all A's, attention, awareness, asterexis, grade 2 is lethargy, disoriented, and then obvious asterexis, grade 3 is somnolent, gross disorientation and bizarre behavior, and lastly findings of central nervous system dysfunction in the form of rigidity, hyperreflexia and clonus, and grade 4 is coma. Coma and decerebrate posturing, sometimes decorticate posturing as well. So this is about the clinical presentation as well as West Haven grading that you need to know for the hepatic encephalopathy. Now, how does the patient develop hepatic encephalopathy? What are the factors? What is the etiopathogenesis? So if the patient is having chronic liver disease, the urea cycle is deficient. The urea cycle that should be happening in the liver is deficient because of chronic liver disease. Okay, that is one factor. On the other hand, the patient is having constipation. Okay, so constipation will increase when the bowel contents are staying in the bowel for a longer time. What happens? There is increased absorption of ammonia from the gut. Okay, so the ammonia is also a direct toxin for the brain here, which is going to cross the blood-brain barrier. And there are infections. The urease producing organisms, when the patient gets infected with it, so the urea is converted to ammonia. Okay, ammonia, when it is being shunted from the portal system, and of course there is also chronic liver disease. Even though there is ammonia in the even though there is urea in the circulation, it is not being detoxified, it is going to get converted to ammonia. Okay, and then because of renal dysfunction, there is reduced ammonia clearance again. So this is also again ammonia clearance. Infections will result in increased production of ammonia, and renal dysfunction will result in the reduced ammonia clearance, and even muscle metabolism. Okay, even muscle metabolism will result. See, muscles are supposed to metabolize ammonia here, and because the patient is also having catabolism, muscle catabolism, that is why there is protein loss and there is reduced muscle mass. Reduced muscle mass means there is reduced ammonia metabolism in the muscles as well, and again the ammonia is going to accumulate in the circulation, and in all the ways, along with portal systemic shunting, all the ammonia in the portal circulation is going to enter into the systemic circulation, which is going to reach the brain and cross the blood-brain barrier, and can result in encephalopathy. Okay, systemic hyperammonemia, that will further result in increased glutamine and the increased lactate levels, because in the presence of glutamine synthase, the ammonia is going to convert to glutamine and there is increased lactate as well. So there are accumulation of other neurotoxins. What are they? If the patient is on benzodiazepines or opioids, which are neurodepressive, right? So these are neurodepressive. So usage of these neurotoxins like benzodiazepines or opioids and the inflammatory mediators like TNF alpha or interleukin 6 can also result in brain dysfunction. Okay. On the other hand, electrolyte abnormalities like hyponatremia and hypokalemia, all of these are going to concurrently will result in the astrocyte swelling and there is brain edema. Okay, there is brain edema. This is on one hand. On the other hand, there is other neurotoxic substances which are mercaptans, short chain fatty acids, manganese, amino acids like tyrosine and tryptophan. All these molecules are also neurotoxic, which could be contributing to the hyperammonemia and other neurotoxic compounds that the patient is taking. Okay, and all of them are going to cross the blood-brain barrier. When they cross the blood-brain barrier and reach the cortex, that's when the patient develops hepatic encephalopathy. That is about the pathogenesis. Now, on evaluation, what are you going to do? You are going to do psychometric testing. Okay, what are the different psychometric tests? Okay, you just have to remember the names. So you have a number connection test. You will ask the patient to connect the numbers. For example, here is 1, 2, 3, 4. So you're taking a pen and a pencil and paper. These charts will be present on the paper itself, and you'll give a pencil to the patient and you will ask the patient to draw the lines between these numbers. Ask him to follow 1, 2, 3, and I'll connect all these dots. And if the patient is able to do it, then it is okay. Otherwise, if the patient is not able to do it, then you can call it as abnormal psychometric testing, which could help in the assessment of the hepatic encephalopathy score. Psychometric hepatic encephalopathy score, or FES. Okay, assessing, which will assess the attention, visual perception, and visuo-constructive abilities. Okay, and here as well there is a clear-cut path which is visible, and you'll ask the patient to draw a line without touching these two lines, and the patient should draw the line along this path. Okay, there's a digit symbol test, there is serial dotting test. All these tests are psychometric tests that are used for the diagnosis of hepatic encephalopathy. Then lastly, treatment. How are you going to treat this patient? So firstly, treat the precipitating factors. You know that the patient is having translocation of gut bacteria, increased levels of infections are also going to result in the translocation of bacteria and increased absorption of ammonia from the gut because of constipation. So you want to treat each and every exacerbating factor. Okay, so treat the precipitating factors, and you also want to reduce the electrolyte disturbances. Treat the hyponatremia, treat hypokalemia, and if the patient is dehydrated, hydrate the patient. So if the patient is having constipation, there is increased absorption of ammonia, right? So you want to send the bowel contents out of the body rapidly. That is why you want to give laxative. Okay, there are two kinds of laxatives here. One is lactulose, another one is polyethylene glycol. Okay, one is lactulose, another one is polyethylene glycol. The mechanism of these two laxatives is different. One is what we commonly use is lactulose in our wards, but the preferred one to use in ICU is polyethylene glycol. Why? Because it is there in the mechanisms. Firstly, when you look at the lactulose when you give to the patient, it is when it enters into the colon, it is a non-absorbable disaccharide. Remember, it is a non-absorbable disaccharide. When you usually when you take milk, it contains lactose, right? It will be reabsorbed into the gut after it is broken down by lactase, and it is broken down into further smaller oligo and disaccharides. It is going to be absorbed into the circulation. But here the lactulose is non-absorbable disaccharide. It is going to undergo transition into the large bowel, and in the colon it is going to get fermented. Okay, when it is fermented, there is transition of the pH to the acidic side, and here the ammonia is converted to ammonium. Okay, so the ammonia in the gut is converted to ammonium, and the ammonium is lost in the stool. So here we are reducing the ammonia reabsorption by converting ammonia to ammonium in the gut, and the converted ammonium is going to be lost in the stool. This is what you commonly give in the wards as well as in the OP patients. But if the patient is in ICU, the patient will also be having ileus. That is, the patient is also could also be having bowel dysfunction, and the patient will also have that is paralytic ileus or the reduced bowel motility. In this situation, you want to increase the bowel motility as well, and there is no time for the colonic bacteria to ferment, to further acidify the pH and to further convert the ammonia to ammonium. There is no such time there. I mean, you don't want to give gut that amount of time to stay in the gut. So you want to increase the transit of the bowel. That is why you want to give an osmotic laxative. So the polyethylene glycol is an osmotic laxative. It is going to draw all the fluid from the circulation into the bowel wall, and it is going to increase the rapid, it is going to increase the intestinal transit, and the patient will develop the stool. Okay, and of course, because of this reason of increased transit as well, there is going to be reduced ammonia absorption. So either ways, there is reduced ammonia absorption, but with the lactulose, the ileus is not rated properly, but with the polyethylene glycol, this is particularly given in ICU patients where there is coexistent ileus. In those patients, polyethylene glycol is more useful. So lactulose is the first line therapy. Start with 25 to 60 ml orally, titrated to achieve 2 to 3 soft bowel stools per day. So the patient should pass 2 to 3 times soft stools. Then you also know that the gut bacteria is the one that is responsible. Okay, the gut bacteria is going to result in the production of ammonia because of the presence of urease. So you want to kill all the bacteria in the intestine. So you want to also use a non-absorbable antibiotic. You have given a non-absorbable disaccharide here to convert ammonia to ammonium. You also want to use a non-absorbable antibiotic which will stay in the gut and it will kill all the bacteria in the gut. That is what is rifaximin. Okay. So rifaximin is a non-absorbable antibiotic you want to use for the secondary prophylaxis. Okay, secondary prophylaxis of spontaneous bacterial peritonitis, and this can also be used for the prevention of spontaneous bacterial peritonitis. Okay, on the other hand, this is also useful for the secondary prophylaxis of hepatic encephalopathy, or if the patient is having recurrent hepatic encephalopathy. Okay, if you want to prevent further episodes, again you can give rifaximin. This is going to kill all the gut bacteria, altered bowel bacteria, which has urease, which produces ammonia from urea. And avoid protein restriction, because the protein is the source for the development of ammonia. Avoid protein. Previously we used to say that the protein restriction should be done significantly, but the current guidelines say the protein intake should be at least 1 gram per kg per day. Okay, 1 gram per kg per day. Previously what we used to say, the protein should be significantly reduced in the diet to reduce the production of ammonia, but the current guidelines say that the protein intake should be maintained at 1 gram per kg per day. So don't excessively restrict the proteins in the diet. So keep it at a normal protein intake of 1 gram per kg per day, and consider L-ornithine, L-aspartate or LOLA or branched chain amino acids to lower ammonia. Okay, so this is going to suppress further levels of ammonia. And if the patient is not responding to the hepatic encephalopathy, again the last resort, like hepatopulmonary syndrome or hepatorenal syndrome or refractory ascites, the last resort is liver transplantation. Okay, so that is about the management of hepatic encephalopathy. So what are they going to give? You are going to reduce the production of ammonia in the bowel wall by giving lactulose, or you want to increase the intestinal transit, again by giving lactulose or polyethylene glycol. You want to kill all the altered gut bacteria in the bowel by giving rifaximin. You can also use it for secondary prophylaxis if required. You can also use it for the prevention of spontaneous bacterial peritonitis as well, right? And the protein restriction should not be done vigorously. It should be maintained at a dose of 1 gram per kg per day. And you can also consider L-ornithine, L-aspartate, which will resume the urea cycle, which will act as a substrate for the urea cycle, complete it, and detoxify the ammonia to lower the production of ammonia. And finally, if the patient is medically refractory or if the patient is having recurrent hepatic encephalopathy, liver transplantation is the last resort. Right, that is about the cirrhosis and the chronic liver disease and all the complications of chronic liver disease. We'll end this here. Thank you for your attention.